and welcome to our listeners to another edition of the JASN podcast series. I'm Kurella Tamura, Deputy Editor of Clinical Science at JASN, and I'm pleased to introduce Dr. Charles Ginsberg from UC San Diego. Dr. Ginsberg, would you please introduce yourself to our audience?
Sure. Thank you so much for having me. My name is Charles Ginsberg. I'm a nephrologist at the University of California, San Diego. I'm originally from New York. I did my med school and residency training at WashU in St. Louis. I came out to UCSD for fellowship, and then I joined faculty in 2018. My research focuses are primarily twofold: mineral metabolism abnormalities in patients with kidney disease, as well as diabetic kidney disease. And I know that's what we're going to talk about today.
Great. Well, welcome to the JASN podcast. So today we're going to talk about an exciting study in JASN led by Dr. Ginsberg, acetazolamide therapy and kidney function in persons with nonalbuminuric diabetes mellitus type 1. Maybe let me just set the stage here. So we know acetazolamide has been around for ages. It's used for altitude sickness and glaucoma, or in diuretic-resistant heart failure. And your study examines a new way of thinking about this old drug. We also know that unfortunately, people with type 1 diabetes are at high risk for kidney failure over the course of their lives. And one of the mechanisms that causes this is glomerular hyperfiltration. It's like your kidney engine is revving way too hard all the time, right? So let me start by asking, what do we know about the mechanism of kidney protection from the existing therapies we have for diabetic kidney disease, RAS blockade, of course, but also the newer therapies like SGLT2 inhibitors?
Sure. So one common denominator in all therapies that have been proven to benefit diabetic kidneys, as well as most proteinuric kidney diseases, is correction of this hyperfiltration process. Sometimes this is called causing the renal dip or renal checkmark in the creatinine. And what I mean by that is if you give a patient an ACE inhibitor, we know that their creatinine might go up a little bit and their GFR might go down a little bit because we're telling the kidney to relax a little, not work so hard. Patients are often alarmed by this because their numbers get a little worse for a few days or a few weeks. But we know that that's a good thing. And that's been shown with ACEs and with ARBs and with SGLT2 inhibitors and with intensive blood glucose control and with intensive blood pressure control. All of these things have been shown to benefit kidneys in the long term, but in the short term, they tell the kidney to not rev up so much, to relax a little and not work as hard. When your GFR or your kidney function is in, say, the 80, 90% range, or even if it's overworking over 100% of what's expected, giving up a few points of GFR isn't going to cause a problem. But in the long term, generally, if you follow people for more than a couple of years, you start to see that they do better and their GFR lasts longer.
Great. Well, thanks. I want to talk about SGLT2 inhibitors for just a minute before we transition to your study. We all know SGLT2 inhibitors have been game-changing for treating type 2 diabetes and reducing the risk for kidney disease, but there's a catch, right? When it comes to SGLT2 inhibitors and type 1 diabetes, and I wondered if you could touch on that for a moment.
There's two issues with SGLT2s. They, as you said, they're fantastic drugs. They lower risk of ESRD by 30 to 40% in type 2 diabetics. That's like twice the benefit of an ACE inhibitor. So the issue with them is, so firstly, they increase your risk of diabetic ketoacidosis, and this is especially true in people who are type 1 diabetes who are already more likely to do so or to develop diabetic ketoacidosis. For this reason, the FDA has consistently put a black box warning, essentially saying, don't give these drugs to type 1 diabetics. Now, with proper monitoring, maybe this is feasible and you can give this, and there are studies that certainly give these drugs to type 1 diabetics. There may be a way to do this safely, but certainly there are some patients, many of them type 1 diabetics, cannot take SGLT2 inhibitors. So that we have the patients who are at the highest risk, type 1 diabetics, are missing out on probably the best benefit, SGLT2 inhibitors. And if we dive into the mechanism of action of SGLT2 inhibitors, which will transition to why we're thinking about acetazolamide. So the way that SGLT2 inhibitors benefit kidneys has nothing to do with how it affects glucose, or at least that's what most experts think. It has to do with its effects on sodium in the kidney, namely that it blocks sodium reabsorption, and it blocks sodium reabsorption in the beginning or the proximal portion of the kidney, unlike some other diuretics which work in different parts of the kidney. This blockage of sodium causes the kidney through a process called tubuloglomerular feedback, which is a big word, and so I'll just say TGF in the future. Through TGF, the kidney senses that it's wasting too much salt, and therefore it cuts down the pressure in the kidney so that there's less filtration in the kidney so that you don't lose too much salt. And so
It's like sticking with the car analogy, it's like in the kidney's own internal speed control.
that's right. The kidney thinks, oh, things are getting too revved up. We need to cut back. We need to relax a little bit. And so when you give patients SGLT2 inhibitors, because of this effect on sodium, you get this reduction in GFR, which we know if you follow people out for more than about 2 years, you can start to see that their GFR is actually better than people who don't get SGLT2 inhibitors. We have proved this is not we, but others have proven this over and over again in type 2 diabetes. And we generally assume this would work just as well in type 1 diabetes because the diseases in the kidney are very, very similar, if not identical. But there's just this safety issue. And this safety issue with SGLT2s for DKA, but there's also for diabetic ketoacidosis, but there's other safety issues with SGLT2s. There's lots of people who we want to put on SGLT2 inhibitors, but can't take them for other reasons, recurrent urinary infections, allergy to the medication. So there's lots of populations out there that would benefit from this kind of drug, but can't take this particular drug. And type 1 diabetes seems like the highest risk, easy to isolate population, which is why we studied them.
I think that's a great segue to talk about your study. So maybe we should start by talking a little bit about the mechanism of action of acetazolamide in the kidneys and why it might work for treating type 1 diabetes.
So as we were discussing, SGLT2 stands for sodium glucose transporter inhibitor, right? And basically, my boss, Joe Ix, and I were talking about how wouldn't it be great if we could get rid of the G in SGLT2 and just have the S, right? Does anything just block S and not affect G? Because G is the problem for diabetic ketoacidosis. And so we were like, well, there's one other proximal tubular sodium inhibitor, and that's acetazolamide, or that class of medications called carbonic anhydrase inhibitors, which have actually been around since 1949, I think. So they've been around forever. And partially because they've been around forever, there haven't been a lot of big studies on them in the last 50 years because there's no real pharma company behind acetazolamide. It's extremely cheap. But essentially, what acetazolamide does is it inhibits an enzyme in the kidney as well as elsewhere called carbonic anhydrase, which without getting too deep into the weeds, is necessary to allow sodium and hydrogen ion exchange in the proximal tubule. So it's a different transporter of sodium than SGLT2 inhibitors, where it's a sodium glucose. Here it's sodium and a hydrogen ion or proton exchange. So essentially, what acetazolamide results in is a diuresis because you can't reabsorb sodium in the proximal tubule without any known effect on glucose. And so because of this property, it was used as a diuretic. It's also used in patients who are alkalotic. This drug causes worsening acidosis or correction of alkalosis, which often happens when we diurese patients. And so that's really what it's been used for in large part. But no one's really, or almost no one, has really looked at acetazolamide with respect to its similarities to SGLT2s and having those benefits independent of diuretic effects.
I think that's a really helpful explanation. So maybe let's move on and talk a little bit about your study. Can you tell us maybe first a little bit about the study design, who were the participants involved, and what was the intervention?
Sure. So we basically wanted to recruit type 1 diabetics because they can't, or they're generally not given SGLT2s. And we were pretty broad and inclusive because as I'll get to, our intervention and our outcome wasn't a long-term kidney disease outcome. So we really just wanted to recruit people as easily as possible. And so what we were looking at is essentially, are we correcting or are we seeing evidence that we would be correcting this evidence of hyperfiltration that exists in type 1 diabetics? So our outcome is often considered counterintuitive to many nephrologists or people who are thinking about the kidney, in that we were looking to see, do we cause an acute reduction in GFR with acetazolamide, as you do with ACEs and SGLT2s, et cetera. And then to prove we're not actually hurting people, when you stop it, do you get your GFR back? Because with all those therapies, we know you come off the drug, your GFR goes back to where you were because you're not harming the kidney, you're just having the kidney relax. Because we weren't interested in diuresing these patients, which is what acetazolamide is developed to do, we didn't want to study the clinical doses of acetazolamide because diuresis was not the goal, and because we wanted to avoid the complication side effects of acetazolamide like acidosis. So we gave patients 2 weeks of acetazolamide and then washed them out of acetazolamide. And we did this 3 times at 3 different doses: 62.5, 125, and 250 milligrams twice daily. For reference, 250 twice daily is generally the lowest clinical dose you'll ever see somebody given acetazolamide. In heart failure or in other treatments, you're normally talking about 500 or 1,000 milligrams. The outcome we measured in a couple ways. Our primary way we looked at it, because we were looking at changes in GFR, we wanted to use the gold standard GFR measurement, which is measured GFR, which was based on iohexol. We also looked at estimated glomerular filtration rate, which we're all a little more familiar with, based on creatinine and cystatin. So essentially, what we were looking to see is, can we induce reversible declines in GFR without causing major side effect issues, acidosis, etc.
That's great. That's a really great explanation. So let's dive into the results. You found that acetazolamide reduced GFR, measured GFR, by about 15%, corresponding to an absolute reduction of about 13 to 14 mLs per minute. And this is the key part. You also found that GFR recovered back to baseline when between each dose and then after the final washout. So the GFR reduction, as you were alluding to earlier, was in fact reversible. And then you also found that weight loss was modest, about less than half a kilo, I think, at the end of 2 weeks of therapy. So, how should we interpret these findings?
We wanted to show that we caused this a reversible GFR decline, and we did. And depending on which dose you look at, you'll see some differences. In the measured GFR, they were all fairly similar, but in the eGFR was more dose dependent, and we're not totally clear on why that is, but nonetheless, it was a pretty universal signal. The reasons we followed weight and blood pressure, as well as KIM-1 levels, which I'll get into in a minute, is we all know that if you cause dehydration, GFR goes down because you make people volume depleted. And so we wanted to show that what we're doing is not just a general diuretic effect, it's effect of tubular-glomerular feedback, as we hypothesize. Notably, there's a clinical trial that was done years ago by someone named Zingerman, where they looked at acetazolamide in obesity to see a similar pattern of effects on hyperfiltration. They had a very similar question. They only did it in a few people, and they actually compared acetazolamide to Lasix in that study, and they showed that about 300 milligrams of acetazolamide is only equivalent to about 2 milligrams of Lasix with respect to diuretic effects. And in their study, they showed acetazolamide has this GFR effect, but Lasix did not. So we didn't compare to Lasix, we compared to just their washout. And so when we saw that level of weight decline, which was not statistically significant, it led us to say, okay, they're probably not too volume depleted if all they've lost is an insignificant half kilo. And then we ran a regression model to see how much of the GFR change can be explained by that insignificant reduction in weight. And it was essentially nil, meaning that there was no relationship between the weight change and what happens to their GFR, and then in recovery similarly. So it seems like what we're doing isn't really diuresing these patients. If we are diuresing these patients, it's extremely minimal. And again, you don't see these signals when you give patients more powerful diuretics unless you really cause volume depletion. So I think we're pretty convinced that we didn't. Similarly, we measured KIM-1, which is a renal injury biomarker, to see, are we hurting the kidney, and KIM-1 did not change. In fact, I believe KIM-1 actually went down slightly on therapy. It wasn't significant, but it's pretty reassuring that we're not hurting people here. We're probably doing something similar to what you get with these other drugs.
We should maybe back up and give some context about who were the patients who were recruited into the study. So you mentioned these were all patients with type 1 diabetes. What was the range of their GFR and proteinuria levels? Do you know if, like, were these all patients who were already maximized on RAS blockade?
So no, we cast a broad net. Our inclusion exclusion criteria basically said if you're type 1 and your GFR is above 45, you can be in the trial. And we can get into why we drew 45 as the cut point, but that's where we drew it. But our type 1 diabetic population at UCSD, especially the ones that want to participate in studies, are very, very well managed. And so we basically took the first 12 people to come through the door. And those people, none of them had any detectable albuminuria. There was, I think, one patient who at one visit may have had like 5 milligrams of albumin in their urine, but most of them were totally undetectable. For that reason, I think only two, I'd have to look back at the paper. I think two patients may have been on an ACE inhibitor. The rest had not yet been started on an ACE inhibitor because they weren't hypertensive and they didn't have albuminuria. If an albuminuric patient showed up, they would have been enrolled in the trial. And we are now starting an albuminuria trial, specifically enrolling people based on that criteria. But recruiting people from a relatively rare disease, obviously it's not that rare, but it's rare, certainly rarer than type 2. It can be hard, especially in a single center, if you are very strict in your inclusion. So for the primary outcome we were interested in, we didn't need people to have evidence of kidney disease, but certainly we want to do it in people with evidence of kidney disease. However, in the long run, when we think about who we would give this drug to, it would be early in the course, like almost all of our therapies. So I think this is an important population to study it in. But if you really want to prove efficacy, you really need to study higher risk patients. And because the endocrinologists and the patients we have are doing such a fantastic job, these people were probably not very high risk.
That's helpful to kind of understand the population and sort of where they were in the course of their kidney disease. So it sounds like these are really, really early, or maybe not even don't have evidence of kidney disease yet. Let's talk a little bit about the potential side effects or lack of side effects, I guess. First, did acetazolamide affect blood glucose, or did it affect the risk for ketoacidosis?
We didn't see any signal that there was any glucose effect. We didn't see any cases of DKA. Obviously, it's pretty short and a small number. Even if you gave people SGLT2s, if it was this brief, I doubt you'd find it too much DKA. We didn't see any evidence of increased ketosis with therapy. So, as expected, acetazolamide's been around for 75 years. We're looking into a isolated kind of niche effect that can easily go understudied. If acetazolamide had meaningful effects on blood glucose, we'd probably know already, and we didn't see any evidence of that. Where we do see some evidence for a side effect is with acidosis, and I'm happy to jump into that. So if you look at the heart failure trials again at side effect profiles with bicarb, you'll on average see about a 6 point drop in bicarb with acetazolamide, but those are based on when you use IV acetazolamide from around 500 to 1500 milligrams a day. And so we're not doing nearly that. We saw about, I believe, a 2 to 4 point reduction. Let me take a quick peek again because I don't want to get this wrong. Yeah, about a 2 to 4 point reduction depending on dose in bicarb. Now that's a 2 week drop. What happens at 6 months? I don't think we know yet. We have a longer study going on to see, does the kidney start making up for that difference or not? I think we're in a changing landscape with respect to bicarb right now. We used to try to keep bicarb at 22 or 24, and more recent guidelines suggest maybe we can go to 18. I don't think those guidelines are built around causing acidosis. I think they're really built around the natural acidosis that results from CKD. But I think the takeaway I have from this is if you have a patient with a bicarb of 20, there's a good chance they're not going to tolerate this medication because if they drop to 16, everyone treats 16, pretty much everyone. So now you're talking about putting them on bicarb supplementation to make up for their acetazolamide, which you certainly can do, but then you run into pill burden issues. It's a twice-a-day drug, and it's probably for life. So if you tell a patient, hey, you need to take acetazolamide twice a day and 4 bicarb tablets or over the day. Now you're adding 6 pills a day to a patient. That's hard. Maybe you'll do it for some patients, but probably most you can't. But if your patient's bicarb's 26 and it goes to 22, does that matter? I don't know. I think we need to do longer studies to find out. I'd probably rather their bicarb be 26 than 22, but I certainly wouldn't treat a bicarb of 22. So that's why we need longer data. Other safety stuff that can come up with acetazolamide. Hypokalemia has been reported. We didn't see any real meaningful potassium effects. No one got hypokalemic. There's case reports of aplastic anemia. There's case reports of liver injury. We didn't see any evidence of that either. The other thing you always have to watch out for with acetazolamide, and this comes to why we drew a cutoff at 45, is in patients with a GFR under 30, it can be neurotoxic. It can cause confusion, altered mental status. So you might say, then why didn't we recruit down to 30? And the reason is because we hypothesized a GFR reduction, right? So if you start at 32 and I'm expecting you to drop 10%, well, suddenly 2 weeks into the trial, your drug is contraindicated. So unlike SGLT2s, where the question was, is it going to be efficacious at a low GFR? And it probably is. With acetazolamide, it's not really a question of efficacy when GFR gets low. It's really more of a question of safety. So we're not really planning to study. We wouldn't be interested really in studying lower GFRs below 45 unless we had really good evidence that this was having a significant benefit to our patients. And this is really early phases. So, if fast forward 10 years, we look at acetazolamide as the alternative to SGLT2s, well, then maybe we can look at lower GFRs. But until such time, I don't think it's a good idea.
I want to circle back to something really interesting that you mentioned about pilot studies looking at acetazolamide in obesity. That caught my attention because it sort of opens up this avenue, or this study does certainly, of acetazolamide treating all sorts of kidney diseases associated with hyperfiltration. Type 1 diabetes is maybe the most common example, but there are others like obesity-related hyperfiltration. So that leads me to the question of, do we know whether acetazolamide affects other markers of hyperfiltration like albuminuria?
Yeah, so there is one study that has looked at this question with respect to albuminuria. The obesity study was only looking at measured GFR and fractional excretion of lithium, which is a surrogate for tubular glomerular feedback. We don't need to get into that. And their findings were consistent with ours. There is one study that I could find on acetazolamide and albuminuria. It's from the late 80s, and it's in type 1 diabetes. And it was 7 patients, and they were given acetazolamide, I think, for 3 days. Now, those patients had about 1,000 milligrams of albuminuria a day. And after 3 days of acetazolamide, it dropped by over 90%. Now, if acetazolamide caused a 90% reduction in albuminuria, I think we'd know it by now because we've accidentally or for other reasons given albuminuria to proteinuric patients so many times that, if your albuminuria went down 25%, you might not notice because it's noisy. But if it cured your nephrotic syndrome, I think somebody'd have picked up on it. So it's
We
the only
don't
data. Go ahead.
I was just going to say, but maybe we haven't picked up on it because we don't use acetazolamide as chronic therapy that much.
Right. And we're starting this albuminuria trial now. And if we're talking about reductions in that degree, well, this is going to be a game changer medication far outside of just type 1 diabetes. There's nothing out there that lowers albuminuria by 90%. So I'm a little skeptical, not of the science behind it, but just that what they found wasn't by random chance, that really there's a confidence interval around that 90% and it's wide. It doesn't cross zero, but it's wide. So with SGLT2s, you see about a 40% reduction in albuminuria if you look at patients with at least microalbuminuria. Acetazolamide's effect on GFR seems bigger than SGLT2s because we were seeing comparable effects to SGLT2s with the lowest doses of acetazolamide. So could it be a little bit of a bigger effect? I could believe that. I hope so. But it's hard for me to think that there's a cure for proteinuria out there, and it's been around for 75 years, and we just happen to be the first ones, especially because we didn't publish this. This is a group from 1989. I would think if they really bought it, they'd have been banging the drum on this a long time ago. We've known proteinuria is bad for a long time, But, one way to find out if that's the only thing that's in the literature, we need to update the literature. And if we see 60% reductions, I'll be thrilled. If we see 20% reduction, I'll be thrilled because we need drugs to lower proteinuria in diabetics. But across the board, a key question will always be, does it add anything if you're already on an SGLT2? I'm skeptical. I kind of view it as giving it an ACE and an ARB. Like once you're on one, you're not going to get much benefit from the other. But that's again something that'll eventually need to be tested if we see efficacy, and probably in patients who have heavier proteinuria, the benefits would be greater. If you have 100 milligrams of albuminuria and you're on an SGLT2, do you need much more? Probably not. But if you have 4 grams, maybe. It's really just speculation.
Well, this has been really a fascinating discussion and helping us, think through the possibilities now for type 1 diabetes. I want to maybe, as we close, I want to kind of look to the future of therapy in type 1 diabetes and put in a plug for another JASN publication. So JASN just published another study on sotagliflozin, I think I'm pronouncing that correctly, which is a dual inhibitor of SGLT1 and 2 in persons with type 1 diabetes, the in tandem trials. So I'm going to ask you to speculate. And I know there's always some caution about speculating, but where do you think acetazolamide might fall in the armamentarium of kidney protection therapies for people with type 1 diabetes? And as we just talked about, maybe for people with other forms of hyperfiltration.
I read through that paper in Jason on soda, and I think if you have the right patient, SGLT2s in type 1 diabetes makes good sense. If you can have good monitoring of their glucose, they're reliable, there's probably an avenue to doing that. But I would suggest some caution because that those trials were not powered, as almost any trial can be powered, around a side effect. So, there isn't a statistically significant difference in DKA in drug versus placebo, but you would need so many thousands of people to prove that. Most of the studies I've seen suggest the risk of a DKA is somewhere in the neighborhood of 1 to 5%, but that's over a year. We're talking about a lifetime therapy. What's the risk over a lifetime? How risky is it if you develop DKA once from a drug? I don't think we have good answers to those questions. But I did do some counting for in tandem. And in the patients who didn't have CKD, there were 29 cases of DKA on drug and 0 on placebo. So they couldn't estimate risk because 29 over 0 is infinity. In the CKD, 8 people on soda had DKA, 1 had placebo. Now, these numbers are small relative to the total study population. I don't remember offhand the total N, but it's a big number. So we're not talking about a huge percent of patients. It's a small percent of patients. But when you see 29 in one group versus 0 in another group, it's pretty clear they do increase your risk of DKA. At least that's the way I see it. I can tell you in my own clinical experience, I once gave an SGLT2 inhibitor to a patient I thought had type 2 diabetes. I found later they had type 1 diabetes, and I found that out because they went into DKA. So I think these drugs have a space if you pick your patients well, reliable patients, good monitoring, you can do this. But that's not work for all patients. And I think people often, we're used to managing patients in academic settings that are very well resourced and realizing that that doesn't always apply to the patient population at large. The other issue is just cost. SGLT2 inhibitors can be expensive, especially if you're underinsured. Acetazolamide is cheap.
I mean,
So
I think that's what the real game changer is here, right? Like acetazolamide is so accessible, whereas SGLT2 inhibitors, like it or not, they're still not widely accessible to many patients. So that's, to me, one of the really exciting pieces. And sorry, I didn't mean to interrupt,
no,
but
no, I think that's right.
and I think, patients have different side effect profiles, so it's always great to have options. It may not always be a question of which is the best. It's just nice to have options.
Yeah, I think, when I was going through training, proteinuric kidney disease had one treatment, ACEs and ARBs, right? And now we are building an armamentarium, SGLT2s, mineralocorticoid, maybe GLP-1s. It's good to have one more if we can. I think the benefit and the struggle go hand in hand in that If a nephrologist out there reads my paper or our paper and says, I want to start doing this, they can. Nothing's going to stop them. I'm not advocating that, but they can because you can give acetazolamide to anybody you want. It costs nothing. The problem is if you want to study 1,000 people, let alone the fact that it's hard to find 1,000 type 1 diabetics, is who's going to pay for it, right? These in tandem trials, I'm sure, had some sponsorship with the company that makes soda because they want to make they need to make a profit off of it. The companies that sell acetazolamide are generic companies, and they're generally not interested in supporting this kind of research. I can say that because I've reached out to them and they don't seem that interested. And so it's harder to do the studies that I really would love to do, like look at incident ESRD or something like that, or GFR decline. But we're working on it. We're working towards it.
Well, this has been such a thought-provoking discussion. Maybe I'm going to let you close with some final thoughts. What should JASN listeners be thinking of or looking forward to in terms of the next steps for acetazolamide therapy in type 1 diabetes?
I think the big next steps are twofold. So, like I said, I don't think we'll ever be able to do a trial targeting incident end-stage kidney disease. So the two things I really want to look at are, does acetazolamide cause sustained reductions in proteinuria? I think that would go a long way to saying that this is a beneficial drug. And that's probably the easiest study to do because you don't need to follow people for that many years. And there's lots of type 1 diabetes with diabetics with proteinuria. The other thing is looking to follow people longer and seeing, do you get GFR benefits? And we're working on studies to look at both of those things. I think those are going to be the
Would
things.
those be like with measured GFR? Can you do a study with large numbers of people
I
using
don't
measured
I don't
GFR?
think so, but I don't think it's necessary. Measured GFR is really good if I want to compare my GFR to your GFR because the process will give us a very accurate description and say, okay, your GFR is better than mine. But if I'm looking at my GFR versus my GFR, the assumptions that go into the equation don't really change and don't matter that much. If it assumes I have this much muscle, but I have that much muscle, unless I, start bodybuilding in the middle of the trial, it's not going to matter that much. The gender issues don't matter that much as long as that doesn't change during the study. So EGFR is, and we use this clinically for this reason, it's great at detecting changes within an individual. It's just not great at comparing different individuals. And these studies would primarily be looking at changes within individuals. So we would definitely be shifting to an EGFR model. Proof of principle, we want MGFR, and we thought it looked cooler in a grant too. But I think going forward, those studies would logistically be better served by just using EGFR.
Well, Dr. Ginsberg, thanks so much for sharing your insights with us. I have definitely learned a lot, and I'm sure that JASN listeners have too. We're all going to be looking forward to seeing what comes next from your research team. Thanks again for joining us today.
Thank you so much for having me.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.